To invite Dr. Suven Bhattacharjee now to talk about phaco in a small pupil, and who will be better than him, who is expert in managing a small pupil, and he's known for his innovation, the BHEX, and we all are fan of his the expander devices. Dr. Suven.
Yeah. Good morning, everybody, and thank you, Professor Titial, once again for this very kind invitation and honor, and those very kind words of encouragement, as always. I am going to speak on a small pupil, Phacoemulsification small pupil, and I do have a financial interest in the BHEX that I'll be talking about. Now, you cannot separate IFIS and small people. They're married and they're going to live together for all their life. So, why is small pupil a problem? When the pupil size comes down by half, the viewing area for the surgeon comes down by to a quarter. It's reduced to a quarter, and that leads to vision threatening complications. Now, again, why is it a problem? Because intraoperative meiosis is unpredictable. So, there is a question always between whether it's iris hooks or pupil expanders. Well, let's address both of them. So, this was a video which I presented in ASCRS and it was widely circulated. So, let's look at this case where despite iris retractors, I'm having a lot of IFIS. Before I could finish my capsulorhexis, the iris is already frayed over there and it's looking like a fishing net over there. And then and of course, you know, once the iris touches the phaco tip, it keeps sticking to it. So, and as I am doing my chops, the knuckle of iris over there. So, this is iris hooks which could not prevent IFIS. That's the patulous iris, as you see that which viscoelastic being injected. Of course, I had to take care while I was injecting the IOL. So, that is about iris hooks, and you saw IFIS with iris hooks. This is a case where I've used the BHEX pupil expander. I would like to believe that it does prevent IFIS. Well, it doesn't. You can see that knuckle of iris over there and at the main incision. So, it is probably not the device which causes the IFIS or has a great role in prevention of IFIS. So, how does a device help in IFIS? Now, as we know, IFIS has three components: floppy iris, meiosis, and iris prolapse. It's the meiosis part which the device takes care of. It provides a constant pupil size for good visibility and safe phacoemulsification. That's what a device is meant for. It's not for the prolapse of the iris. That depends on the severity of the IFIS and pathological damage to the iris by the device, by the disease itself. So, if you have IFIS in one case with a device and you don't have IFIS in another case with a particular device, there's no credit to the device. It's just the severity of the IFIS which is different in the two cases. Now, there is another big question about whether to use a device or not to device. There are skilled surgeons, super skilled surgeons, superhuman surgeons, and different types. But just put yourself in the patient's shoes and say, if you have a 4 millimeter pupil and you are undergoing a cataract surgery, what would you like your surgeon to do? Show his heroic skills in doing a non-device surgery, or to use a device and be safe rather than sorry? So, that is a thought I think you would like to spend some time. Now, these are the predisposing causes for IFIS, and as days are going by, we know the list is getting longer and longer. Hypertension itself is a risk for IFIS, and almost 80% of our patients are hypertensive when they come to the table. So, there is no amount of history taking which can prevent or anticipate the risk of IFIS. So, every case that comes on your table is a potential IFIS risk. Now, can preoperative dilatation in your office or OPD help you predict IFIS? Well, unfortunately, no. Even a 7 millimeter pupil runs the risk of IFIS as per this paper. Is IFIS less common in India? Unfortunately, no. It's actually much higher in India. The use of tamsulosin is much higher in India, and hypertension. This is a wonderful paper. If you have not read it, you must read it. It's a wonderful paper published in India a few years back by Shilpa Goyal and colleagues. And hypertension was identified as an important risk factor over here. Fortunately, surgeons have lowered their threshold now. More devices are available, experiences they're gaining. So, because IFIS is unpredictable, as I said, we have more exacting expectations from patients, and Cellular Society, as we know, and premium IOL technology is very unforgiving. So, we know that. So, let's get back to how did IFIS or understanding IFIS change the whole game? So, Chang and Campbell told us in 2005 that non-elastic meiotic pupils, unlike the non-elastic meiotic pupils, the IFS pupil immediately snaps back to its original size following attempts to stretch it. So, if you want to have mechanical dilatation, it's in IFS pupil, no amount of stretching, pupil stretching is going to help, whereas if it's a rigid fibrotic pupil, you might get away with a controlled stretching. There are various devices. We have principally lived with the iris hooks for a long time, and then we have the rings and devices like the Mulligan ring, the BHEX, the I-ring, there are a few more other. So, an important concept in small pupil is there are just two types. One is elastic and the other is non-elastic or the rigid type. This is a concept which I actually faced when I was developing the device, and I think I promoted this, and we were aware of it, but probably we did not define it so well, and thereafter I think there has been a recognition, and people the term rigid pupil and elastic pupil has become more popular. I'm happy it's now. So elastic pupil is like a rubber band. Any pupil expander would work. A rigid or a fibrous pupil is like a string. You can keep stretching it, it's not going to stretch. You have to tear it. So you need to break that fibrous ring with either the device, which could be bulky, or use two Kuglen hooks to provide controlled stretching before you use the device. There is a way in which we can check the elasticity of the pupil before we start. As soon as you've made the paracentesis, inject BSS into the anterior chamber and inflate the anterior chamber. If the pupil momentarily expands, that will tell you the extent to which it is elastic. So that gives you a clue, and you now know how to go about it. If it does not budge, you know it's a rigid pupil, and it is, no amount of inflation of viscoelastic was going to help. So it might as well go ahead and do a controlled stretch, and that makes it a rigid pupil actually an elastic pupil or a stretchable pupil, so to say. So what matters most is the elasticity of the pupil and not the size. Another question which we often ask is, how large do we want the pupil to be? Now, honestly, all phaco surgeons with the kind of fluidics, knowledge of fluidics we have, or the machines that we have, if you are assured as a phaco surgeon that you're going to get given a pupil which is 5 millimeters and it's not going to come down further, I think all of us can do a surgery. So a device needs to just expand the pupil to 5 or 5.5 millimeters, and that is good enough to not damage the sphincter. You want that sphincter action also later on. Let's look at this rigid pupil pseudoexfoliation. Thanks to Dr. Deepak Megur for this wonderful video. A little bit of stretch over there. So anything less than 4 millimeter and rigid, it's good to stretch. And the BX is being used. This is just about 5.5 to 5.75, nothing more than that. And it's a pretty hard cataract, as you can see. You can always chop it into small fragments, and that will allow you to deliver those fragments and kind of consume them with the phaco probe. And of course, this is the BX, which is very easy to insert and remove. Where do we inject viscoelastic? We need to inject viscoelastic under the pupil margin and not actually inflate the anterior chamber. Inflate the anterior chamber, you plaster the iris to the lens capsule, and actually that leaves little space for the device. So inject little viscoelastic under the pupil margin and cause a little bit of bowing so that you can it's easy to use your device. Now this is a BHEX pupil expander being used in a 1.8 to 2.2 millimeter incision. It actually goes through much smaller. I'll show you in the next video. So it's basically a little bit of viscoelastic over there, and you take the device, carry the device into the antechamber, tuck alternate flanges under the pupil margin. Under direct visualization, you don't have any guessing work as to whether it's engaged or not. And then you have a 5.5 pupil, which allows you enough room for a good capsulorhexis, followed by a very safe phacoemulsification and cortical cleanup and IOL implantation. I mean, you actually have enough visibility to do all the steps pretty safely. And you can even actually go under the pupil, under the IOL, and do your viscoelastic removal. It's no different from a well-dilated pupil. So you can do all your maneuvers, and especially if you're doing a toric lens, you would like to see those marks over there. Removal is very easy. Just grab a flange, advance it centrally, it disengages, and the trailing flanges, trailing notches actually disengage spontaneously. Now this is a 1.2 millimeter incision. This was presented at the ASCRS meeting, and you can see there. And now what happens with such a small incision is that when you hold the device across, the flange across the incision, it will not go through. So instead, if you can hold it at the notch flange junction, that the device aligns longitudinally, and it's much easier to take it into a much smaller incision. We do this again when we remove it through the side port. So that is a 1.2. I don't think a device exists other than BX which can go through such a small incision. Now, you can remove it through a 0.9 millimeter side port incision. Again, that could be very useful in IFIS where you have the iris prolapsing through all ports. Just grab a flange, draw it centrally, disengage the two notches on either side, and then drag it out. No rocket science over there, no great skill required. The trailing notches just disengage spontaneously. Iris hooks, let's talk about a little bit. This is a very old video. I have not been doing iris hooks for quite some time. So we need to inject viscoelastic and we need to just put those small nicks on the conjunctiva. Helps identify those parasyntheses that are sometimes very embarrassing. You take the hook and you can't identify it. Retract the stopper far enough in advance, otherwise again it's embarrassing. You've come to put it inside and the stopper has not been retracted far enough. I would always recommend that you don't do a full retraction. About a 5.5 to 6 is very good. Don't get carried away by the size of the pupil over here. Now keep the pupil as control as you would like to. Remember, the pupil margin now with iris hooks is always at practically the limbal plane. And moreover, often the pupil margin is anti-flexed, so that when you insert your side port instruments, you could damage it. So removing the hooks is actually very easy. Hold that stopper, advance the device, and just yank it out, and it momentarily, it's polypropylene, so it momentarily straightens. And that should be enough for the iris hooks. Now, there are certain concerns with iris hooks. Yes, I do have a bias. There are more number of incisions. Sphincter tear is more common. The way corner spaces are actually wasted. So, and like I said, it's the pupil plane is elevated, and there is a publication which says that iris hooks takes more time. Guess it's true, and of course the cosmetic damage. So a favorable pupil device in IFIS is which requires small incisions, has a low vertical profile, can exit through the side port, and so the iris hooks and the BX I think serve the purpose pretty well. Let's skip this. In intraoperative meiosis, actually it's again, the devices which all exist like Malugan ring, they have a vertical profile which engages the pupil margin. The BX, the notches being horizontal, you can tuck the flanges under direct visualization without engaging the capsulorhexis margin, and you have instant confirmation that you have not engaged the capsulorhexis margin.
And welcome.
So this is Dr. David Chang had shown it in AO, and this is in the American Academy website. So choice of pupil expander, it's intraoperative meiosis, is either iris hooks or the BX. And in subluxated cataracts, I would definitely go for the iris hooks because you can control the clock hours where you would like better visualization. These are some resources which you have online. Thank you very much for your kind attention. Thank you.
Thank you, Suven. Wonderful presentation. I think very, very helpful that you have shown so many techniques to make it comfortable in insertion as well as taking out, and even after the, in between the surgeries also. Sometimes other expanders are very difficult to use when you are in between the surgery, and people shift to iris hooks there, but your thing can go there also.